Let's flip this ahead to the next one. Oh, there we go. So up next, Lindi Rigg and Kaylee Faber, who are both research support assistants. Did I get that right? Close enough. I'm just going to step away because you can read the title and they can tell you more about it. So welcome them, please.
Well, hello everyone. Thank you so much for joining us today. My name is Kaylee Faber and I am a current PhD student attending the University of South Florida. I'm originally from Oklahoma. I obtained my Master's of Public Health from Oklahoma State University with a focus on rural and underserved populations. Lindi and I will be co-presenting today, so I'll give her a minute to kind of introduce herself.
Good morning, everyone. My name is Lindi Rigg. I'm a doctoral candidate in counselor education and supervision. I'm also a licensed mental health counselor and supervisor in the state of Florida. Right now, Kaylee and I are working with the University of South Florida on a research project. We are part of a larger research team headed by Dr. Rigg as our principal investigator and Dr. Stephen Proctor as our co-investigator. So we're sharing some of our research with you guys today.
Okay, so our session today will be talking through preferences for method of delivery for family-based interventions in opioid treatment. So traditionally, interventions for substance use disorders have been provided either in person or through telehealth. And recently, we've seen a significant increase in substance use services. Apologies. So we've seen a significant increase in substance use services being delivered remotely. But there's still a lot that we don't know about whether patients and providers have a preference for a method of delivery, either in person or via telehealth, especially whenever it comes to family-based interventions and opioid treatment programs. So in this study, we set out to explore and understand those preferences among both opioid treatment program patients and providers. So both face-to-face and telehealth service delivery come with their own set of challenges and benefits. One advantage of in-person sessions is that nonverbal cues can be seen more easily by providers, which can help them understand possible concerns with the patient. In-person sessions reduce the likelihood of distractions, which that can be more common during telehealth appointments. On the other hand, traveling to a treatment facility, that can be expensive and it can be inconvenient, and a lack of transportation can be a major barrier for some patients. Telehealth helps to bridge this gap by allowing services to be delivered remotely, making treatment more accessible, especially for those who may have a busy schedule or physical disabilities or those who live in rural areas. That said, telehealth isn't without its own challenges. Patients need reliable internet or cell service, as well as access to a phone, a tablet, or a computer. And for individuals who live in rural areas or have a lower income, or those who just feel uncomfortable with technology, this digital divide can make telehealth less feasible. So now we'll take a look at what the research says about preferences for face-to-face versus telehealth services. Unfortunately, the findings have been pretty mixed. Some studies suggest that patients with substance use disorder feel telehealth weakens the patient-provider relationship, while others highlight concerns about privacy and confidentiality, especially patients who are just first starting their telehealth services. Providers have also reported frustrations as many patients struggle with the technology, which can make the appointments more challenging. On the flip side, research has also shown high levels of patient satisfaction with telehealth. In fact, a recent study found that more than 3/4 of patients preferred remote services, with key benefits being that it reduced social barriers and increased convenience. Providers have also acknowledged the advantages of telehealth's ability to expand access to care. So overall, the literature is divided. Some patients and providers prefer telehealth, while others prefer face-to-face services. And on top of that, most of these studies don't look specifically at preferences for delivering family-based services, specifically in opioid treatment programs. So that gap in the research is what led us to focus on this area in our study. So this study was part of a larger program evaluation of Families Facing the Future, or FFF. FFF is designed to support parents in recovery by helping prevent relapse, by providing coping strategies if relapse were to occur, and also teaching parenting skills to reduce the risk of substance use in their children. Currently, FFF is delivered entirely face-to-face with group sessions lasting about 90 minutes, and they take place in person at an opioid treatment program. There is case management services that are offered, and that's in the patient's home. For this study, patient participants had to be at least 18 years old, currently receiving methadone for opioid use disorder, and have a child between the ages of 5 and 17. Providers had to be at least 18 years old, working as a behavioral health provider, such as a counselor, a social worker, a certified addiction professional at an opioid treatment program. We collected data from 40 participants, so 20 patients and 20 providers, between August and October of 2022 at 2 different opioid treatment programs in Southwest Florida. Participants first completed a short 5-minute survey on an iPad answering some basic demographic questions through Qualtrics, and then they took part in an in-depth qualitative interview focused on their preferences for how FFF services should be delivered, either face-to-face or via telehealth. The interviews were semi-structured, meaning that we asked specific questions, but we allowed the conversation to just flow naturally as new ideas emerged. And on average, the interviews lasted about 30 to 40 minutes, with participants receiving a $50 Amazon e-gift card for their time. And then finally, we analyzed all of the data using in vivo to identify different key themes and participant responses, which is what Lindi is going to talk us through at this time.
Great, thank you, Kaylee. So actually, I'm going to start with just a little bit of background on our sample characteristics. This is just background of our participants. Starting with age, our patients' mean age was 37. Providers were slightly older at 43. In terms of gender, the majority of our participants were female, 65% overall. Moving on to race, our sample was predominantly white with 65%, with blacks making up 17.5%, and a smaller representation of Asian Pacific Islanders, biracial and multiracial, both at 5%. Regarding ethnicity, 15% of both groups were Hispanic, and for employment status, all of the providers worked full-time, and 85% of patients worked full-time. So we're going to look at our key themes. There were 4 key themes that emerged from our interviews. The first was concern about child engagement. The study did show a high degree of similarity across preferences between patients and providers regarding their preference for delivery. With the concerns for engaging children, there was the sense that adults can maintain their focus for longer periods of time. Children struggle with shorter attention spans. They get easily distracted. They're more prone to getting distracted by pets, TV noises, anything in the background that can take their attention away from the session. In face-to-face sessions, providers can use specific techniques that can help increase engagement throughout the session. We also found that providers had some concern about just their ability to do that. There's some techniques that they had to use in order to do that. Another major challenge here was working with families that have multiple children. Having 3 or 4 children trying to sit in one place, get seen on the camera, it took up a lot of time and was seen as a waste of time in terms of having to troubleshoot these sort of logistical issues. Our next theme, concerns for communication barriers. Telehealth does introduce some technical issues when it comes to audio-visual issues, delays, freezing, Wi-Fi issues. These sort of interruptions just break the natural flow of conversation that impact communication that's needed for these sessions. So the other piece here too is providers rely heavily on body language, facial expressions, vocal tone. So this is something that can be disrupted sometimes too. If we have poor camera angles, patients don't know how to maneuver the technical issues that's needed. Our participants also believed communication barriers created a sense of distance between them and their provider. Having these breaks and Wi-Fi disruptions, it just sort of prevented connection and building that rapport that was needed. So we definitely encourage having to work with clients to manage these barriers to make it more effective. Okay.
Yeah, this is not.
Okay. Okay. Take a second. Let's see. I'll keep going just for sake of time, and hopefully it'll catch up for us. Yeah. So our third theme that was that emerged from our interviews was concern for recorded content. Both providers and patients strongly preferred live video sessions over pre-recorded content. A lot of treatment programs do use pre-recorded content for topics like relapse prevention, anger management, but it did feel less personal for patients. One of the biggest concerns there is just that there's a limit of two-way conversation. Patients are just receiving information. They're not able to ask the provider questions, and the same for the providers as well, too. They're not able to ask the clients questions to guide the treatment and to understand what's going on with them. Beyond the patient-provider dialogue, live sessions also created opportunity for peer support. Participants emphasized the importance of connecting with other families in group sessions. These real-time discussions allowed families to learn from each other, share experiences, and develop a sense of community. Kaylee and I did a group together, and we saw that patients were like using the emojis there, using the chat function just to support each other, and it definitely created a sense of community and connection. So although pre-recorded content can be convenient, it is still seen as less engaging. Our fourth theme was that there was a preference for telehealth just because of the convenience it provides. Many patients in opioid treatment programs, they already have a hard time traveling for their dosing appointments. So adding another additional appointment for them to travel to was seen as burdensome, unrealistic. Reliable transportation is a major issue, as many patients don't own a car. They rely on public transportation, ride shares. This just gets very expensive, time-consuming, and imagine traveling with multiple children at the same time, too. Telehealth does eliminate these travel-related barriers, making it easier for patients to engage in treatment without these added costs and stress. So it was noted that telehealth did offer some more flexibility for patients, especially those with busy schedules, juggling work, school, court appearances. It was even found that those who were unemployed also had very busy schedules. So the telehealth was seen as very convenient and added some flexibility for them to make the sessions. So being able to eliminate these travel costs, save time, and provide this flexibility was seen as very appealing for a lot of the patients. Our findings did show that telehealth is very promising to delivering these family-based interventions for substance use disorders. There are several pieces that still need to be addressed, and this study is unique in being able to identify first what it looks like in doing family-based interventions and also offering perspectives from both providers and patients together. And with having this high degree of alignment between both, it just suggests that both groups are pretty equally receptive to doing family-based interventions online. So some critical strategies that we suggest to enhance effectiveness, incorporate techniques to engage children when minimizing distractions. So research shows that children respond best to structured sessions, taking frequent breaks, and having interactive activities throughout the session. Providers should work closely with patients to troubleshoot tech issues, especially in that first session. Walking through different pieces of connecting is very, very helpful to mitigate these issues long term. We also recommend using best practice for maximizing capture of nonverbal cues. Sometimes it's working with the patients to Okay, pull your camera back so I can see your full face. You know, I sign on sometimes and the camera's right here. So walking through them, walking with them through these issues can be really helpful for the provider to assess these nonverbal body language pieces that are important to assess. It's also suggested to use live sessions versus pre-recorded content. If pre-recorded content is necessary, it's helpful to provide opportunities for patients to submit questions and get responses from their provider. So our study highlights strengths and challenges to delivering opioid treatment programs in the telehealth format. Our findings show variation in terms of preference. Participants appreciated the convenience of telehealth, but it is still noted that face-to-face does offer more engaging environments for the patients. The biggest advantage in telehealth is that it removes the barriers for transportation and increasing flexibility in schedule. But the key boundaries here that still need addressing are technical issues, weakened patient-provider connections, and therapeutic alliance. So with that, we really encourage using data to drive interventions, data to drive the protocols in order to best meet the needs of patients and providers going forward. So ultimately, the success of telehealth in opioid treatment programs depends on ongoing evaluation and adaptation, and using studies like this to use this insight to implement programming that's patient-centered and that meets the needs of both patients and providers. So thank you all for listening and for being here with us.
Thank you, Lindi and Kaylee. Research support specialists, not assistants, as I said. But there's a microphone there and a couple of minutes if you'd like to, anyone would like to ask a question. If you want to jump to the microphone there. And if you get straight to the point with the question, that will mean we might get some more. But
yes.
thank you.
Thank you.